So here we are going to talk about the nose. Nose is made up of upper lateral cartilages. There are bones also. And here the opening is made up of alar cartilages. And which test we are doing to check the nasal valve blockage? Superior nasal valve blockage, basically we check in this. That test is called as Cotley's test, my dear friends. Saddle nose. Now saddle nose, what is happening? There is a dip on the nose. You can see right here. Most common cause is trauma. Other diseases which can also lead to the damage of a septal bony cartilage and a septal cartilage, they can also contribute to the formation of saddle nose. And if there is a saddle nose, we do the augmentation rhinoplasty. And if question examiner is asking you from where you are taking the graft, your answer is going to be the iliac crest, my dear friend. Next is rolled out edges and exposure to the UV light. I taught you well. Rolled out edges and exposure to the UV light. Yes, this is none other than your rodent ulcer, and which is also called as basal cell carcinoma. Now tell me one thing, this carcinoma metastasize or do not? Your answer is no, they do not metastasize. They do not metastasize. Then coming on to the next one, rhinophyma. There is a sebaceous gland. In the sebaceous gland, there will be a hypertrophy. Because of the hypertrophy, there will be a biggie nose looking like a potato. That is why this is called as potato nose. In this, what you need to do, you need to remove this with the help of CO2 laser excision. Plus, you can put the skin graft also. The foreign body in the nose is a mass. Mostly it is unilateral. Mass is present. Foul smelling discharge is coming outside from that area. Plus minus epistaxis, depends if you are, what type of foreign body it is. Now, you will do an X-ray of nasal spine, AP and lateral view. AP view is sufficient to know, and with the help of endoscope, you will remove it, my dear friends. Myiasis is a maggot formation inside the ear and nose also, and to remove that we use a maggot oil which is made up of chloroform and turpentine. Chloroform and turpentine. Now nasal bone fracture is there. Now most common bone to get fracture, nasal bone, X-ray, lateral spine we are doing right here. We can see the fracture. Now sir, what you will do? Before the edema start, try to reduce it with the help of a Walsham forceps. And now your question is, why sir, if edema has already started, then what we'll do? If edema has already started, then you will reduce the edema. You can wait for 5-7 days, and after that you will do the reduction of the bone, my dear friends. Nasal septum fracture, two type of forces we have to talk about. One is force coming from the front, one is force coming from the below. If the force is coming from the front, this is horizontal or gingival fracture, and if force is coming from the below, it will lead towards your vertical or 𝗲𝗲𝗃 fracture. Now blowout fracture we have talked about. Mid-face fracture. Mid-face fracture of maxilla. First one is transverse fracture, second word is pyramidal fracture, third is craniofacial dysfunction. In both of them, you are going to see the CSF rhinorrhea. CSF rhinorrhea. And in this, you are going to see the bleeding 𝗖𝗵𝗍 on the hard palate, which is called as Guarin sign. Which is called as Guarin sign. Now, coming on to the next part, sir. Guarin sign. Very good. Now, CSF rhinorrhea. CSF rhinorrhea, the most common cause is idiopathic. Traumatic cause, if we talk about anterior cranial fossa fracture, is the most common cause. Otherwise, non-traumatic, most common cause is idiopathic, and in idiopathic, second thing is what getting damage is cribriform plate. Cribriform plate, my dear friends. Now, the most common here, how to diagnose it? First of all, clinical test is where you will see a halo sign or target sign. Otherwise, to confirm it whether this is CSF or not. The CSF other than mucoid, how you will differentiate? Mucoid is 𝗵𝗵𝗆 type of appearance, and CSF is continuously running nose. And here your test you are going to perform, the test you are going to perform is beta-2 transferrin estimate. How to find the site of leak? So my dear friend, site of leak you will find with the help of HRCT, and also treatment is conservative. You will ask patient to maintain some positions plus antibiotics so that infection should not go inside the brain. Now paranasal sinuses we have to talk about, my dear friends. Paranasal sinuses are 4 in number. The biggest, largest is the maxillary sinus, then followed by sphenoid sinus, ethmoid sinus and frontal sinus. These are the 4 type of sinus we have to read about. Now this anterior ethmoid air cell is having 2 type of things. One is bulla ethmoidalis and agar nasal. Bulla ethmoidalis is most constant and the largest air cell. Agar nasal is anterior, most anterior air cell. Then posterior ethmoid air cell can then posterior ethmoid air cell is there. Now let's talk about the other thing is other thing is, sir, middle meatus. It is made up of three structures. What are those three structures, sir? BUE, bulla ethmoidalis, uncinate process, and ethmoid infundibulum. They make a osteometal complex. In the sinusitis, what happens? There will be a inflammation, and the causative organism, causative things can be allergy, can be any bacteria, virus. They can lead to also your inflammation of a mucus that will lead to the closure of the nasal cavity. Now, sinusitis is basically closure of the osteometal complex, because, and if sinusitis is more than 3 months, we call that as chronic. And what are the chief complaint? Nasal discharge will be there, nasal blockage will be there, post nasal drip will be there, बहता नाक आगे की तरफ बहेगा बंद होने की वजह से, और पीछे की मवाद पीछे की तरफ चलेगी, हाइपोस्मिया भी हो सकता है, हेडेक भी हो सकती है इसके अंदर, साइनोसाइटिस के अंदर, यस हेडेक का फीचर है ना. Now coming to next one. Next one is investigation. In the sinusitis case, Waters view is done. On the 30 degree, this view is done and rays are passed from behind. Only sinus which is not visible here is a sphenoid sinus. For sphenoid sinus, we do a open mouth test, and open mouth is called as Pieris view. Cardwell is not that much used these days. Let's only read about the Waters view. Now, CT-PNS is the best investigation. First investigation is X-ray Waters view, but examiner is asking you about the best investigation. Then your answer is CT-PNS, paranasal sinus, paranasal sinus. Now, sir, complication of sinusitis, orbital infection, mucocele formation, pot-puffy tumor. This all happens. Mucocele formation and pot-puffy, they happen in the frontal sinus. So you will see the puffy swelling, you will see Duffy swelling over here. It required an operation called as FES. FES stands for functional endoscopic sinus surgery. Functional endoscopic sinus surgery. Now, long-term complication of FES is Seneca formation. For Seneca formation, endoscopic removal we do. Also, we use mitomycin C. Mitomycin C. Now, tumor of paranasal sinus, most commonly they are associated with the maxillary, ethmoid, frontal, and the sphenoid sinus. Now, what is happening to check the prognosis? There will be Ongren's line. Below that, there will be a poor prognosis. Above that, there will be a good prognosis. Also, there will be a loss of dentation, plus palate can also go. For this, we need a surgery called as Weber-Fuggerson approach के साथ में total maxillectomy we do, and that approach is called as, most commonly which is used, Weber-Fuggerson approach. Now, let's talk about the vocal polyp. AC polyp and your ethmoid polyp. AC polyp originate from the middle meatus, from maxillary sinus, and it will go to the posterior choana. It is 1 in number. And here in the ethmoid polyp, they are multiple in number. And ethmoidal polyps are most commonly seen in the children, and AC polyps are most commonly seen in the adult. AC polyps are most commonly seen in the children, and ethmoid polyps are, which are more in number, they are seen in the adult. For them, the causative organism is allergy. Sometimes that is why corticosteroid we give. If not getting resolved, then we go for the surgery. In the AC polyp, we go for the endoscopic removal. We go for what's your endoscopic removal. Endoscopic removal, my dear friends. Then coming to this Septal stride में क्या है? Na, that is nasal polyp, asthma and allergy to an NSAID like. Now mucormycosis called by rhizopus or mucor also seen in diabetic young patient. So what is happening? This is angio-invasive fungus. This angio-invasive fungal will do what? It will, through the blood, it will come. It will do the thrombosis. Because of thrombosis, what will happen? There will be the blood supply hampered. There will be necrosis. Necrosis की वजह से वहाँ पे black scar formation हो जाएगा, fungal growth हो जाएगी वहाँ पे. And the drug of choice is liposomal amphotericin B plus debridement we have to do. And how to culture it? Local swab लेके culture कर सकते हैं. If it is going to the brain, we will use a MRI. Done. Coming on to the rhinitis medicamentosa. Now, what is happening in the rhinitis medicamentosa? The patient is using the chronic use of decongestant will lead towards a transient vasodilation. पहले constriction हुआ, फिर vasodilation हुआ, जिसकी वजह से inferior trabeculae की hypertrophy भी हो गई. Now immediately you need to stop those drops and add the steroid drop, my dear friends. Now deviated nasal septum. What is happening in the deviated nasal septum? On the opposite side there will be the closure, and the side which is getting deviated, the patent side you will talk. There will be a compensatory hypertrophy, plus there is going to be the headache, plus there is going to be the nasal blockage. और यहाँ पे inferior turbinate की hypertrophy को तो mulberry like mass नजर आने लग जाएगा. Now we'll do a septoplasty and SMR also we can do. Septoplasty is only correction of the deviated part, and SMR is a correction of deviated part along with all of the septum, whether it is bony septum, whether it is cartilaginous septum. Now sir, septal hematoma also the treatment is incision and drainage. If you will not do, there will be a septal perforation. For that treatment is button, you will put it right there, sir. Now coming to septal perforation के other causes other than the surgery. Sir, it is divided into cartilaginous part and the bony part. Cartilaginous part is getting fracture because of the TB, lupus leprosi, and bony part is getting damaged because of the tertiary syphilis. Who is damaging both? Then the boss is coming, that is your Wegener's granulomatosis. Done. Atrophic rhinitis. Now what is happening in the atrophic rhinitis? The causative organism like 𝗝𝗶𝗹𝗶𝗵 is coming, because of which there will be a mucosa atrophy. Mucosal atrophy is there. Because of that mucosal atrophy, their bone is also getting atrophied, and there is a crust like material which is getting deposited in the nose. Because of that, there will be a foul smell which is coming out to other person, but that person is not having that smell. This is called as merciful anosmia. For such patient, we do a alkaline nasal douching, and if douching is not working, we do a young suppression, modified young, in which we will temporarily close the nasal cavity so that the nasal mucosa can heal, and again the mucus secretion will happen, and this crusting must go on. Then coming to the rhinoscleroma. Rhinoscleroma is caused by 𝗝𝗵𝗃 rhinoscleromatis. This is caused by 𝗝𝗵𝗃 rhinos. This is most commonly seen. Which bodies you are going to see? Russell body and muculi cell you are going to see. Now there is nodular stage, fibrotic stage, then granulomatous stage is there. Nasal deformity is most commonly seen with the fibrotic stage. The tetracycline and streptomycin. The drugs which give is tetracycline and streptomycin. Now rhinosporidiosis. This is protozoal infection caused in the pond, especially in the Tamil Nadu side. Males are most affected. This protozoa goes inside the nose, and there will be a mulberry-like appearance. Once we touch that, there will be a bleeding. Here we'll do the electrocautery of the base plus dapsone. Dapsone prevent it from reoccurrence. Done. Then coming to the epistaxis. Most common area of the epistaxis is Little's area. What is Little's area? It is the anterior inferior quadrant of the nose, and there is an artery of epistaxis which is called as what, sir? Sphenopalatine artery. The artery of epistaxis is sphenopalatine artery. Now coming to the Keelius dehiscens, it is present in the inferior constrictor muscle. It is a muscular weakness from where the outpouching can happen. That is called as Zenker's diverticulum. Laryngopharynx, which is also called as hypopharynx, my dear friend. Three important structure, 3 P's you have to remember here. P1 is pyriform sinus, then there will be post-cricoid area, then posterior pharyngeal wall. The most common site of hypopharyngeal malignancy is going to be your pyriform sinus, and sign you are going to see is absence of laryngeal crepitus. That is going to be the Muri sign, my dear friends, Muri sign. Now nasopharynx is having 2 landmark. One is what, sir? Your adenoid, another is your eustachian tube opening. They both are. Now where is this adenoid? This is adenoid as the roof of the nasopharynx, and it is near to the choana. Now this is a collection of a lymphoid tissue which is now stopping the which is a part of Walde's ring and stopping infection to happen. Now they are feeling, if you will palpate them per oral, they will feel like bag of worm. They are present by birth, grows up to 6 years, and at the time of puberty they start regressing, and by the 20 years of age they will disappear. But there are some time when these adenoids become enlarged and they become the problem, and that problem is most commonly encountered with the school going children, where recurrent URTI, upper respiratory tract infection is a risk factor, and because of that there will be hypertrophy. The patient will be having a adenoid faces. What is adenoid faces? Pinch nose, open mouth, then there will be a high palate, plus there will be a hyporesonate voice. That means nose is closed, the patient will be speaking like a oh, okay. Then there will be a glue ear because of eustachian tube blockage. The adenoid hypertrophy will lead to eustachian tube blockage. Because of that there will be a glue ear, my dear friend. And also that person might be feeling not to eat, failure of thrive will be there, also not able to sleep properly, obstructive sleep. And treatment to adenoid hypertrophy, we do adenoidectomy, we do in the adenoid hypertrophy in the extensor. This is Rose position, and there will be a subluxation of atlantoaxial joint. Now coming to the angiofibroma, sir. Angiofibroma is a benign tumor of the nasopharynx Originating site is in sphenopalatine foramen. Highly vascular, that is why biopsy contraindicated. Hallman-Miller sign or antral sign is here, where posterior maxillary wall is pushed outward. Here also angioembolization we do, and after that we'll do the surgery. Nasopharyngeal carcinoma, the Epstein-Barr virus is a causative organism, plus that there is a predisposition associated with the HLA-B27. Site of origin is a fossa of Rosen-Miller, and most common age is going to be the 52. That is okay. Now, NPC is a hidden cancer. How the first symptom you are going to see? Lymphadenopathy. Which lymph nodes are getting enlarged first? Jugulodigastric nerve. There is a triad called as Trotter stride in the NPC, and that is that Trotter stride, my dear friends. Neuralgic pain, palatal palsy, and conductive hearing loss. As this is a cancer, cancers are mostly unilateral. That is why unilateral conductive hearing loss will be there. Treatment, chemoradiation is better answer than the radiotherapy. Then we are going to the oropharynx, where tonsil is there. Tonsil, there is a palatal tonsil present between anterior and posterior tonsil. Here the tonsil is having crypt, having blood supply, and having the capsule. This, sir, remember the tonsillar blood supply mainly is by tonsillar branch of the facial artery, and drainage with the paratonsillar vein. Now, mostly the question which is asked in the exam is about the tonsillectomy method. Most common method is dissection and snare method. Remember, what are the complications which can happen, my dear friends? That is your primary, reactionary, and secondary. Primary is during the surgery, reactionary is within 24 hours, slippage of ligature or slough formation is not there. Then secondary, we can do more than 5 days, there will be infection, IV antibiotics we have to give, sir. Now coming on to the quinsy. What is quinsy, sir? Quinsy is a peritonsillar abscess, which is a collection of pus between tonsil and its beds. You will push other side, tonsil push medially. Yes, there is going to be throat pain, dysphagia is going to be there, trismus is going to be there, hot potato voice is going to be there, but outer neck swelling is absent. If all the features are like quinsy and outer neck swelling is present, then your answer is going to be the parapharyngeal abscess, my dear friends. Then coming to Ludwig angina, flora mouth, dental caries की वजह से infection होगी. Most common muscle involved with mylohyoid muscle, and the area involved with submandibular, submental. These areas are involved. Okay. Now, there will be, if this swelling is growing too large, there will be a hot potato voice, there will be trismus, throat pain, respiratory difficulties will be there. And normally we give the antibiotics plus external incision and drainage we do. And if it is severe, obstructing your airways, then you have to go for tracheostomy also, my dear friends. Now coming to the larynx. Larynx is a voice box. It is covered by 3 cartilages, 3 paired and 3 unpaired. Paired are just rudimentary, they went. Unpaired cartilages are important. What are 3 unpaired cartilages? We talk about thyroid cartilage is like an open book. In a male, it is making 90-degree angle. In female, it is making 120-degree angle. And remember, it is making the Adam's apple, my dear friend. Cricoid cartilage is ring-like, and epiglottis, if we talk about, it is leaf-like, cover the vocal cord. Now, keratosis larynx. What is happening? The pseudo-certified squamous layer is covered by the keratin cells. Keratin cell, it is looking more white. On the video laryngoscopy, we'll check what is the cause for that. Chronic irritation, and irritation because of 𝗧𝗲𝗹𝗵𝗺, irritation because of drinking, irritation because of chronic allergies also. In that condition, we do the stripping off. Whatever keratin layer is deposited there, we will remove it, and we will use the CO2 laser chordectomy we will do. And hoarseness of voice is a feature which will be the alarming sign, because of which we will do the further investigation. Now coming on to the puerphonia, endophomia, we all know. Sir, now coming to the enlarged saccule, which is called as laryngocele. Moment the patient is doing Valsalva, you will see there is the dilation of the sac right here. Dilation of the saccule right here, and this is most commonly seen with the trumpet blowers. Trumpet blower. Now coming to the next one, sir. Next important thing we have to talk about, vocal polyp versus vocal nodule. Vocal nodule is a bilateral condition, vocal polyp is a unilateral condition. But treatment is vocal nodule is voice rest. In the vocal polyp, the treatment is microlaryngeal surgery. Microlaryngeal surgery. Now we talk about the intubation granuloma, faulty granuloma happening on the posterior 2/3. Vocal nodule and polyp, they are happening on the anterior 1/3. But intubation granuloma is happening on the posterior 2/3. And here the treatment is microlaryngeal surgery like the vocal nodule. Now coming to the Rhinitis edema, there is a Rhinitis space in which, because of the permeability increase, there is a fluid filled in that, and because of which there will be the hoarseness of voice you will going to see. Treatment is quit smoking, voice rest plus stripping of vocal cord mucosa, and again the irritation to the vocal cord is happening right there. Juvenile papilloma is a vertical infection causing from mother to the child, and remember HPV 6 and 11, young child 3 to 6 year, child with the hoarseness of voice with the respiratory difficulty. In this also we do the MLS, that is microlaryngeal surgery, along with the CO2 laser. Now coming to the Stridor, we got three types of Stridor we have studied, my dear friends. Remember, inspiratory, biphasic, inspiratory Stridor is a Stridor happening when there is the topmost structure is involved, that is your supraglottis. In the biphasic, sir, there is going to be the two glottic and subglottic, and the expiratory, there is going to be lungs which are involved in this thoracic, and trachea is involved. Now functional aphonia, our fake female is coming saying you are not, I'm not able to speak, and in that cough reflex is present. Laryngomalacia, the weakness of supraglottis there is there. The laryngomalacia, weakness of supraglottis there is an inspiratory Stridor because of the weak supraglottis. There is going to the inspiratory Stridor. You just have to, mother is going to say, typical case, mother will say, मेरा बच्चा रोता है सर, उसके बाद में इसको Stridor बढ़ता है, सर ने बोला है reassure, 12 से 18 महीने लगेंगे, ठीक हो जाएगा. Now coming to the muscles of the larynx, tensor में कौन कौन सा vocalis मेन मसल है एडक्टर के अंदर, इंट्रा थायरोएटिनॉइड. ये इंट्रा और थायरोएटिनॉइड अगर आपका ढंग से काम नहीं करता है, देयर इज अ डिजीज, देयर इज अ abnormal joining of this two vocal cord. This is called as phonesthenia. This condition is called as what, sir? Phonesthenia. Now coming to the bilateral and unilateral abductor palsy, bilateral abductor and bilateral adductor palsy. Bilateral abductor palsy, you are not able to open. You are not able to open. That means voice is normal plus respiratory difficulties there. In this, you will do type 2 thyroplasty. In bilateral adductor palsy, your vocal cords are like this. That means aphonia is there. Respiratory difficulty is not there, but aspiration ke chance hai. In this, you will do type 1 thyroplasty. Type 1 thyro. In the pediatric infection, two infections you have to remember mostly right here, sir. One is your acute epiglottis. Acute epiglottis is because of strep pneumonia, most common than H. influenzae. And here you will see the thumb sign in the acute laryngotracheobronchitis. Basically, there will be a barking cough present, right? And tripod sign is a part of acute epiglottis. Here you are going to see the steeple sign. As there is a respiratory difficulty, the first approach is going to be the manage the airway. Done. Then laryngeal and bronchial foreign body, immediately you have to intervene and remove them. TB larynx had two signs, turbine epiglottis and mouse nibble appearance. Then glottic cancer, we were talking about staging. T1, one structure involved. T1, T2 is more than one structure involved. T3 is vocal cord is fixed. 4 is invasion. For this, the treatment for T3 and T4 is total laryngectomy. What is the mode of voice production after the total laryngectomy? One is your electrolarynx and another is your tracheoesophageal puncture device. This is Bloom's finger prosthesis. How it works? Once you will put finger on the trachea, the opening which you will see right there, then only you will be able to produce the voice. Otherwise, the air will go from esophagus. Otherwise, air will come from this hole only. If you close this, air will come from the esophagus, and there will be an esophageal voice production. Then tracheostomy. In the glottic cancer, we are doing in the high tracheostomy. That was once asked in the exam. That is first and second ring. And most commonly, we are doing between second and third ring. And most common tracheostomy tube which we are using is PVC Portex tube. Indication of tracheostomy also we have studied. More than 7 days plus any kind of maxillofacial trauma is there. In all those scenarios, we do the tracheostomy. Now let's talk about the next topic, and that is called as what, sir? Your ear. Ear is developed from first and second arch. There are 6 hillock of it. They fuse together to form a pinna, my dear friends. And now the tympanic membrane, if you see, tympanic membrane having a landmark, that is lateral process of malleus and umbo. From there, the cone of light is there. This is making a 55-degree angle. Two important parts are there. One is pars tensa and one is pars flaccida. This tympanic membrane is made up of all three: ectoderm, endoderm and mesoderm. Then 3 ossicles are important in case of your ear. Those are malleus, incus and stapes, out of which malleus and incus are made from first arch and stapes is made from the second arch, my dear friends. Now bat ear, if antihelix is absent, that will lead to a condition called as bat ear. Congenital disorder of pinna, number 1 is very important: preauricular sinus. Preauricular sinus is an incomplete fusion of first and second arch. Sir, if asymptomatic, no treatment, nothing. If symptomatic, you have to release the tract. Development of pinna defect, microtia and anotia. Anotia means absence of the pinna, micromecia means small pinna. Now coming to the Darwin tubercle is a conical appearance on the helix. Now boxers or cauliflower ear, because of the boxing, what will happen? There will be a hematoma formation because the cartilaginous and the skin of the pinna skin, sir. And it will lead to the necrosis of the pinna if you will not remove. So treatment is incision and drainage, incision and drainage. If wax is present, up to 30 decibels of hearing loss will be there. Now diseases of external auditory nerve, first of all localized otitis externa, which is also called as फरंकुलोसिस. ये एक बाल की इन्फेक्शन होती है, स्टेफाइलोकोकस के द्वारा होती है. ट्रीटमेंट में हम इसके इक्थामामोल ग्लिसरीन यूज करते हैं क्योंकि इसका एंटी बैक्टीरियल एंटी इन्फ्लेमेटरी एक्शन भी होता है. दैट इज व्हाई इक्थामामोल ग्लिसरीन इज मोस्ट कॉमन. मैलिग्नेंट ओटाइटिस एक्सटर्ना का दूसरा नाम है अपना स्कल बेस ऑस्टियोमाइलाइटिस. ये बोनी ईएसी की होती है. इसमें पेशेंट मोस्टली क्या है, प्रीडिस्पोजिंग फैक्टर यू विल सी सीन इन ओल्ड एंड डायबिटिक पेशेंट. तो ट्रीटमेंट के अंदर एक तो आपने क्या कर दिया, थर्ड जनरेशन सेफेलोस्पोरिन जो कि बैक्टीरियल कॉज के लिए दे दी, और साथ में यू आर कंट्रोलिंग द डायबिटिक ऑल्सो, यू आर कंट्रोलिंग द डायबिटीज ऑल्सो. ऑटोमाइकोसिस फंगल इन्फेक्शन कैन बी कॉज एस्परजिलस नाइगर, ब्लैक कलर के स्पोर्स देगा. कैंडिडा एल्बिकन व्हाइट कलर के पोर्स देगा. पॉजिटिव फैक्टर क्या है, ह्यूमिड एनवायरनमेंट की वजह से होता है. ट्रीटमेंट में क्या करेंगे, सक्शन करेंगे, उसको बाहर निकालेंगे. Plus topical antifungal agent we can use. Why we cannot use the systemic? Because this is non-invasive fungus. This is what, sir? Non-invasive fungal. Now to talk about the eustachian tube. काम क्या होता है, मिडल ईयर वेंटिलेशन का काम होता है, मिडल ईयर सिक्रीशन को बाहर निकालना काम होता है. अगर ये ब्लॉक हो जाए तो मिडल ईयर की सिक्रीशन विल रिमेन इन द मिडल ईयर ओनली. फॉर दैट पर्पस वी डू अ ट्रीटमेंट कॉल्ड एज ग्रोमेट इंसिजन. वी पुट अ ग्रोमेट इन द anterior inferior quadrant and after some days we'll see this grommet will automatically come outside and the patient will be relieved mycin. That traumatic perforation done middle cleft. middle ear diseases में सबसे पहले बात करेंगे ASOM. We talk about the ASOM. Streptococcus pneumoniae is a cause. 5 stages of ASOM you are going to see: tubal occlusion, pre-suppuration, suppuration, stage of resolution and complication. Cartwheel sign is seen in stage 2 and pus discharge will come in stage of resolution. If stage of resolution is not treated, it will lead to the stage of complication, and stage of complication is going to be the safe CSOM. So there is a difference between safe and unsafe CSOM. Unsafe CSOM and safe CSOM discharge. If ज़्यादा भर के discharge आ रहा है, profuse discharge is coming, my dear friends, that is going to be the safe CSOM. If scanty discharge, some small amount of discharge, that is unsafe. Blood stain है, foul smelling है, unsafe है. And if it is not blood stain, not foul smelling, that is going to. Plus, if central perforation is there in the pars tensa, then you will think of a safe. If there is a perforation in the attic part, and then you have to think of a unsafe. The unsafe can lead to choleosteatoma also, which is a bone-eating thing which will eat you. For that, different surgeries approach are needed. And if only your tympanic membrane is damaged, you will do a simple tympanoplasty, which is also called as maryngoplasty, This is unsafe CSM we were talking about. There is a one very famous theory about the choleosteatoma, that is a retraction pocket theory. First there will be retraction, then there will be a destruction, then there will be a squamous metaplasia. From squamous cells will go inside the middle ear. There the keratin will also come. Squamous and keratin plugs will be made, which is called as choleosteoma. They will be eating. Now there are complications of choleosteatoma, unsafe CSOM. If we talk about that will be your intracranial and extracranial complication. The different type of intracranial and extracranial complication is going to be, my dear friends, and those include brain abscess, EDH, SDH. These are going intracranial, and petrositis and sigmoid sinus thrombosis. These are going to be the extracranial complication. Now, sir, we are going to talk about okay, acute mastocytitis. Done. Now let's talk about the fluid in the inner ear. Fluid in the inner ear is endolymph and the perilymph. Endolymph is secreted from stria vascularis, and perilymph is also CSF, which is secreted from the aqueduct of cochlea. Now basal turns are 2/3 turns are there. Upper one is for low frequency, lower is for high frequency. Again a question asked in the exam. Now benign positional vertigo, what is happening? There are two things, utricle and saccule. They are having sensory end organ called as macula. And once the patient is moving this, that, he is having vertigo. For that, diagnosis is Dix-Hallpike maneuver and treatment is Apley's maneuver. So then coming to the audiology. Audiology में conductive hearing loss and sensory hearing. If the problem is still the middle ear, it is conductive hearing loss. If it is in the inner ear, that is going to be associated with the sensory neural hearing loss. Tunic 4 test की बात कर रहे थे sir. First of all, Rhinitis test we do in the 256, 51210 and 1028. Okay. Now sir, if Rhinitis test, how to perform a Rhinitis test? If you are doing Rhinitis test and you are asking your patient आगे से ज़्यादा, that is air conduction, पीछे से ज़्यादा, that is bone conduction. If your patient is saying sir आगे से ज़्यादा सुनाई दे रही है, that means there will be a normal ear or possibility of a SNHL. If your patient is saying nahi doctor साहब मुझे पीछे से ज़्यादा सुना रहा, that means bone conduction is more than air conduction, and that will suggest you of what's your conductive hearing loss. Now Weber test, I'll just put it here, and if patient is saying कि centralized है, that means normal. अगर बोलेगा इस तरफ प्रॉब्लम थी, इसी तरफ जा रहा, that means conductive hearing loss. अगर प्रॉब्लम इस तरफ है और जा रहा दूसरी तरफ, that means there is a sensory neural hearing loss. That means there is a sensory. Then other ABC test is there, which is done by occluding the ear canal. We ask the patient to raise hand when he's not able to listen, and same we put on R also. If we are able to listen, that means normal or conductive hearing loss. If we are not able to listen, that means this is sensory neural hearing loss. Sensory neural. Now special dips are there, 2 dips are there. One is 2000, one is 4000. 2000 is called as Card's notch. 4000 your Bowler's notch is there, and 2000 is because of otosclerosis. 4000 is because of the sensory neural hearing loss. So that is noise induced hearing loss. Presbycusis and Meniere's. Presbycusis both are SNHL. Presbycusis high frequency SNHL, Meniere's is low frequency SNHL, and presbycusis is a bilateral, Meniere's is a unilateral. In presbycusis you are going to see the sloping audiogram, in the Meniere's you are going to see the rising audiogram. Bira has 7 waves, छोटे बच्चों में काम होता है, थोड़ा सा expensive होता है, 5th wave is important होता है. OE electrode से वो Bira जो है वो brainstem से record करता है, OE is recording from the cochlea. And this is cheaper test as compared. Now impedance audiometry, if we talk about, this is comparison of the air and reaction of tympanic membrane and ossicle to that air. That is called as compliance. Sir, if compliance is normal, the curve N will come. If glue ear is there, no compliance, the curve will come flat. If there is a eustachian tube function, there will be a negative pressure. Because of that, the curve will be shifted to the negative side. If there is a otosclerosis, there will be a reduced compliance. Because of reduced compliance, the small curve is going to come. And if there is an increase in compliance, which is seen in the ossicular dislocation, there will be a non-joining line which will look like a volcano mountain, sir. Now coming to the otosclerosis. Otosclerosis is a fixation of foot plate of stapes, and remember here short sign if it is present, the treatment is sodium fluoride. If short sign is not present there, then stepidotomy we do. Stepidotomy से स्टेपिडक्टमी में क्या अंतर होता है? स्टेपिडक्टमी में हम थोड़ा सा छेद करते हैं स्टेपिस के फुट प्लेट में ताकि वो मोबाइल हो जाए, नहीं हो तो अलग से एक फेनेस्ट्रेशन बनाते हैं. Acoustic neuroma is a tumor of a 8th nerve. On MRI, gadolinium enhanced MRI, you are going to see the ice cream in cone appearance, and this is associated neurofibroma type 2. Surgical excision is glomus jugulare is a tumor of jugular bulb which is situated on the floor of the middle ear. Here you will see a brown sign. Redness, red mass blanches on sigillization. Once you are putting a pressure or you can doing a Valsalva, you will see the red mass which is coming out. It will do the sigillization, and this mass is coming out like a rising sun. This is what called a rising sun sign. And on CT you will see a Phelps sign, my dear friends. Now Meniere disease is an episodic disease. It is a ear fullness, might be seen, not be seen, and remember this is also called as glaucoma of the ear. Glaucoma of the ear. The phenomena are like recurrent teleos and diplagos. Recurrent is loud sound, here more loud. Teleo में कभी कभी चक्कर आ जाता है जोर से चिल्लाने में. Diplagosis में same sound is heard at the 2 frequencies. Here the treatment is first of all your medical management. If it fails, endolymphatic decompression surgery we do, and if it still fails, we would do trans-tympanic injection of the gentamicin. Bell's palsy and Ramsay-Hunt syndrome we have discussed already. Ear implant, hearing aid less than 90 पे काम करते हैं. If your 8th nerve is fine, then you will go for the cochlear implant. If your 8th nerve is not fine, you will go for the brainstem implant. If there is a canal stenosis or there is a anoxia, this is absent, then we put a 𝗲𝗲, that is bone anchored hearing aid. In this which we are doing, we are conducting the bone energy directly to the inner ear. Bone energy directly to the inner. This is classification of deafness.